Thank you so much for having us here today and to listen to this presentation. As I mentioned earlier, I'm a clinical social worker by background. I've been a behavioral health director before. I'm now one of the co-founders of XFERALL. Just a slight background, what we're really talking about today is the emergency department psychiatric boarding crisis, and also a lot of opportunity to create efficiency, to centralize processes, and how do we layer on innovative technology to drive quality improvements, staff productivity and efficiency, and also cost efficiency within health systems. So we're going to talk about how we use command center approaches and systems in addition to this technology. So I'm very happy to have Troy here today. Troy is the Senior Director of Crisis Services at Sutter Health. And Sutter Health serves 3.5 million patients across Central and Northern California. Troy and I have known each other for a couple of years now as we launched XFERALL. XFERALL initially launched in Texas, has spread throughout the country, and launched in California about a year and a half ago. We also have one of our key innovative partners in the room as well, Paul Raines, who helped us launch in California. So we brought together a great team, and what it really took to make the difference for behavioral health patients and health systems. And one of the key differentiators about XFERALL is that we don't just exist within one health system. We create networks between health systems to produce the true impact for patients. So I want to start today, Troy, with talking a little bit about the sort of personal mission, and to hear from you what got you interested in this project, and a little bit of that background.
Sure. Thanks. First of all, thanks for having me, Shana. Mm-hmm. I'm really excited to talk about this. It's a subject I'm very passionate about. And we have known each other for a couple of years, but we just started XFERALL basically a little over a year ago. We just hit our 1-year anniversary. We started piloting, and Shana's been trying to get me to come along, like, come talk about XFERALL. And we joke about it because I said, I need to see more proof in the pudding before I come out and talk about the success that we've had. And so now we're a year in, and it's been a wonderful transformation for our organization. You know, 10 to 15 years ago, I think most people in this room could say that they knew somebody that was struggling with their mental health. Unfortunately, and especially since COVID though, it seems like people can now say, I know somebody who's taken their own life or attempted to take their life. And that's kind of a reflection on just how bad things have gotten in our society. And also, in almost all of these cases, it seems that the healthcare system has pretty much failed this patient population, and that's usually due to access problems. That's what we're experiencing in Northern California. And there's too much fragmentation, and that fragmentation has taken a toll, first of all, on our patients that are going through psychiatric crisis, but also on our frontline staff. Now at Sutter Health, we operate 21 emergency departments across Northern California. I actually sat down and did the math. Once every 10 minutes, a patient or a person will walk into one of our Sutter EDs with a mental health concern. Think about that for a minute. Every 10 minutes around the clock, somebody is walking into one of our 21 EDs with a behavioral health crisis. And so for people who do come into our emergency departments in crisis, I've watched our ED teams actually struggle and try to find placement for these patients that need that higher level of care, sometimes on the phone for hours doing, playing phone tag with psychiatric facilities trying to get a transfer going at the expense of other patients that are sitting in the emergency department lobby waiting for a bed or, to get back. And so, my why is really about restoring dignity to the process, right? And making sure that when someone is in psychiatric crisis, that we're responding with the same level of urgency and coordination that we would for a stroke or a heart attack.
Mm-hmm. Thank you, Troy. I think that when we talk about a lot of the return on investment, what is really powerful is that when we can we can look at the data and we can look at outcomes, but the real impact that we see oftentimes is with the quality of care that that patient can get, and also returning the staff away from manual-based practices and being able to do the job they need to do, which is to be a clinician with the patients. I'd like to hear a little bit about the process you went through to develop the command center, implement that. What were some of the strategies that you had that led you to centralize, and what were some of the success factors to align the leadership within the organization to move to this new model?
Yeah, we had a lot of chaos going on before we started TransFerAll. We had 21 different hospital EDs that were doing their own thing, 21 different ways, if you will, all with their own workflows, all with their own Rolodex of favorite psych facilities, often duplicating efforts. And that was really, really inefficient. And so we understood really early on that in order to fix this problem, we weren't going to be able to optimize it locally, but rather let's take a systematic approach. So we actually built what we call now affectionately known as our TransFerAll Command Center, in which all of the referrals that come into Sutter Health, because we also operate 4 of our own psych hospitals, every referral that comes in, either from external or even from one of our own hospitals, goes through this central command center model. And I think to answer your question around the process, we did actually have a behavioral health transfer center already in place, a mental health patient access center, if you will. And they were doing a really good job of sort of organizing and getting all of the referrals into one central location. But we still had that problem of where do we send these referrals to if we don't have beds of our own. So, creating this centralized command center and this behavioral health transfer center that we stood up before that really allowed us to start toying with the idea of standardizing workflows, looking at bed availability from an enterprise level and things like that. And also it allowed us to really start freeing up our ED staff to start focusing on care rather than logistics. That was going on a lot. And I like to call it kind of a command and control type of model that we could scale. And even though we didn't know it at the time, because we actually stood this command center up prior to TransFerAll, but it really did set the stage perfectly for TransFerAll.
Mm-hmm. Troy, can you talk us through a little bit of when you did implement TransFerAll, what was the change? What was it like before, and then what happened when you implemented TransFerAll? What was that like for your team, and a little bit about the real-time technology and how that enhanced the transfer center model?
Yeah, I'll just say this too. At Sutter Health, we weren't really looking for a vendor. We were actually just looking for a solution to a system-wide problem. And as I mentioned earlier, before we implemented our TransFerAll Command Center, our EDs were spending hours on the phone, faxing clinical packets out to anyone that they could think of to try to find a psychiatric bed. It was inefficient. It was demoralizing, and worst of all, I think it really delayed care for a lot of these patients that were in crisis. But today I'm proud to say that actually that process is now centralized and digitized, and now our behavioral health transfer center manages all referrals through one single platform with TransFerAll. And that means our ED teams can now focus on stabilizing patients and not chasing down beds. And we've seen a huge reduction in our ED door-to-door time as a result of this. We're 11 hospitals into this now. We have 21 EDs, so we're about halfway through. And that has really translated into hours of clinician time reclaimed. We now have social workers who are able to respond more quickly to the bedside when a patient does come into one of our EDs and get that patient to the higher level of care faster. But I think really one of the more meaningful shifts has been really in how our care teams are operating. They're not working on logistics anymore. They're really just spending time at the bedside, engaging families, And what we've just started to realize is that when we can have clinicians at the bedtime more quickly and not in some office, a floor away in the hospital, trying to find beds, that they're actually able to spend more time at the bedside, and we're starting to see them be able to stabilize these patients in the ED and even forego an inpatient psychiatric transfer altogether, and that's a huge win for everyone.
Troy, one of the things that I think can be a complex challenge is managing change with these types of shifts. People get used to the types of tasks that they have to do. Sometimes you can see internal pushback against these change. Talk a little bit about how that may have happened at Sutter and how you're able to manage some of that.
She's laughing because we've had to deal with this a lot. So, centralizing really meant that we had to redefine some roles, and that's just not easy. We have previously we had ED nurses who were responsible and used to managing transfers themselves, and now we were asking them to trust a centralized team that was off actually in another state altogether. Our centralized command center is in Utah, so that was interesting. Social workers had to learn a new platform. We had to stand up some communicate. We use Microsoft Teams a lot at Sutter, so we had to stand up new communication channels. And so this whole change management piece, I think I underestimated that a little bit. We actually had to deal with resistance. We had teams that were pushing back. And so I'm saying this in case you're thinking about moving to this, be aware that you may find some pushback within your local teams who are doing this today for you. So a lot of skepticism, resistance, and so we had to really over communicate things. We had to provide hands-on training, little no-do shares or one-page guides. Found out the hard way that's not the best way to train somebody. You really have to take the time to work with the staff in your emergency department who are now kind of turning this work over, and we created some feedback loops too. Mm-hmm. We wanted there to be a way for them to be able to tell us what's working, what's not working, so that we can continue to iterate and improve upon the process, and also just so that they could feel heard. Mm-hmm. And we didn't learn that. We did a 6-month pilot with 4 of our hospitals, and we kind of learned the hard way from that process. We should have probably thought about change management a little bit here. And so we started implementing some of those change management practices once we started scaling beyond our pilot. And I'll just say change fatigue is very, very real. We're a large organization. We just had a new CEO take over a couple of years ago, and he's driving the ship very fast. And so this came around the same time we were doing that. So change fatigue is real. And we just really kind of had to pace ourselves and then actually celebrate some of the small wins.
Yeah, absolutely. Well, now I'd like to get into some of the results and talk about what were you able to achieve through the centralization and the technology? What did you see there?
Yeah, so I'll talk about what worked and what didn't work a little bit here. So I think what worked best was transparency. We realized that right from the beginning. We started sharing data early and often with the emergency department leaders. We showed how the new model was actually improving throughput and really reducing physician burnout as well. I actually went to an ED Chiefs meeting about a year before we started XFERALL, and 21 emergency department chiefs, so you can imagine what this might have been like. And the topic of physician burnout did come up. And I asked, what is the single most impactful thing that really affects physician burnout? I expected them to talk about the EHR and documentation and all of that. And I was really surprised at how many of our ED leaders said it's those behavioral health patients. They medically clear them, they get them ready to be transferred, and then they sit in the emergency department for hours, days. We had a patient in one of our rural hospitals just last week that was there for a week, And I was talking to somebody today from another large system who said, well, I can take your weekend up that. We've had patients in our EDs for 30 days. And so some of you may have experienced that yourself. And there's nothing more frustrating for an ED physician who's already done their job to triage the patient, get them medically cleared, than have to come in day after day, shift after shift, and see the same patient there 2 days, 3 days, 4 days later. So that whole idea of reducing physician burnout, I never really factored that into one of the benefits of TransFerAll. On the screen here, you can see the actual ED length of stay reduction, but don't underestimate the impact that it has on physician burnout. I would say what didn't work was assuming that one round of training was going to be enough. Talked about this a little bit before with the change management piece, and I think personally I underestimated the need for ongoing support after we went live. And I think if I could do it all over again, if I could go back in the past, I'd really invest more upfront in change agents, people embedded into each of the EDs who could be there to champion this new model and troubleshoot it in real time. But we do track a lot of metrics around TransFerAll. The ones that matter the most to me really are the ones that reflect the patient experience as well as staff efficiency. And you can see on the screen here behind me, since launching our command center model at Sutter Health and integrating TransFerAll into that, we've seen almost a 15% reduction in ED door-to-door times, and that's system-wide. That's a system-wide number with only 11 of our 21 emergency departments implemented so far. I think there's another slide here. Yeah, this is interesting too. We were never able to track this before, but with TransFerAll, we're now able to see how quickly the first psychiatric facility out in the community responds to our request for a psych bed. And our median time from the time that we put that referral into this network system until the first hospital says, yeah, we're interested in that patient is 20 seconds, which is mind-blowing. And then the median acceptance time is well under 2 hours. And then we have this other slide here. I really like this slide. It kind of shows you the trend over time. And you can see about halfway through this chart, a decrease, a pretty sharp decrease beginning to happen in our overall ED length of stay. We first implemented TransFerAll in June of last year. And that was, again, with just 4 pilot sites. And we've been phasing it in more of our hospitals over time. So I'm really excited to see how much lower we can get this number to go as we implement the other 10 hospitals in our system. And we have another graph here. I'll just say that these aren't so much operational wins as they are what I'd call quality of care wins. Over the past 5 years, our behavioral health transfer center at Sutter Health has processed over 140,000 behavioral health referrals. And we've placed more than 37,000 of those patients into inpatient psych units. So that scale to me tells that this model works.
One of the other things that we take a look at and has been mentioned is there's so many different types of cost to this problem. There's the patient cost, there's quality of care cost, there's cost of the other patients that are waiting to get into the emergency department. We know that when capacity goes up in the emergency department, mortality rates go up. So this problem impacts every single patient that comes into the emergency department, not just your behavioral health patients. So by solving this problem, we improve the quality of care for behavioral health patients, but we also improve the quality of care for every other patient that's trying to walk into that emergency department. And there's a huge financial cost because the cost of taking care of behavioral health patients long-term in the emergency department is significant. So by being able to move them, we improve the quality of care for the patients, improve the staff experience, and we also create a more cost-effective health system. So Troy, as we move forward and as we sort of wrap up the talk today, talk about what your advice may be for any healthcare leaders in the audience and any final words you may have to add.
Yeah, I think if there's one thing that I've learned through the TransFerAll journey is that this transformation doesn't start with technology. It actually starts with belief, right? So belief that we can do better for our patients who are in psychiatric crisis, belief that our teams deserve systems that actually support and not strain them, belief that even in a complex, fragmented behavioral health landscape, that we can build something that works.
Mm-hmm. Well, Troy, thank you so much for being here and talking about this. It's been a pleasure to work with you. It's been a pleasure to work with those of you who are in the audience who we work with. And for those of you who don't work with, we would love to partner with you and collaborate to really work on solving this problem as we move forward. Thank you so much.